Okay, I'm going to speak in next maybe 8-9 minutes about endovascular management of pulmonary embolism. Now, pulmonary embolism, as we all know, it has a very, very grave prognosis, and it has an anatomical and clinical classification. It could be acute or chronic, depending on the time duration, massive or submassive, or a minor one. And massive pulmonary embolism is defined as pulmonary embolism involving main pulmonary artery and both pulmonary arteries, branch pulmonary arteries, and the patient being in cardiogenic shock. We have various treatment options. They could be thrombolysis, they could be catheter-directed mechanical thromboaspiration or thrombectomy, or could be a surgical thrombectomy. Now, indications for percutaneous pulmonary thrombectomy for massive pulmonary embolism. These are patients who are in cardiogenic shock, and patients who have failed thrombolysis, and patients who have contraindications for thrombolysis. Our experience actually started a few years back with this patient who was 36 years old male, had a road traffic accident, and had multiple cranial injuries. On the second post-op day, the patient developed a massive pulmonary embolism, was in cardiogenic shock with a deeply desaturated and a heart rate of 140. And because of intracranial hemorrhage, the anticoagulation was totally contraindicated, and he was too high risk for surgery, so we had to do something, and he was referred to us to do something. And we took the patient to the cath lab. We did a right femoral groin entry, and we put a 10 French sheath. Luckily, we had the 10 French guiding catheters, which we were using in DCA, the old ones. And we could take this catheter on a guide wire and pull out and clot from the main pulmonary artery and from the branch pulmonary arteries. Now, this is what we did. After we sucked out clot from the main pulmonary artery, we went selectively into each of the branch pulmonary arteries. This is from the left lower lobe. And this is after we sucked out. So it almost clears the artery by 60-70%. And then we go ahead and with the wire and do the same thing in the lingular lobe, in the left upper lobe. And we suck out a lot of clot, and the patient's saturation start improving. Whatever clot is left, then we take a wire and try to macerate the clot so that it flows distally, and it is sort of becomes amenable for spontaneous lysis. So on the left side, once we complete the left lower lobe, upper lobe, and the lingular lobe arteries, we go on the right side and do the same thing for the right lower lobe pulmonary artery, and then we go and macerate the clot, and this is the result after cleaning up the right lower pulmonary artery. Then we go and do the middle lobe artery, and then the right upper lobe artery. And then we put a IVC filter in this patient. So we don't want there's a total contraindication of thrombolysis, and this is the type of clots which we suck out. Much of it is actually liquid while liquefied when we take it out, but there are some solid portions as well. And some of the clots are really long, and it's very rewarding procedure. In this patient, the saturation improved immediately from 70%, 80% to about 90%, and that too on the room air. Post-op, the pulmonary artery pressure dropped to almost normal. The BP rose to 130 by 8 DCA guiding cath. We didn't have access to angiojet device at that point of time. Subsequently, we have done similar patients where thrombolysis is totally contraindicated in about 26 patients. And we had procedural success in all of them. One patient died because of intracranial hemorrhage, not because of the procedure. And in most of the patients, there was at least a 50% drop in pulmonary artery pressure on the table. And there was a clot burden which was decreased by 50% in all except one patient. The procedural saturation improvement, most of the patients had a normal saturation after the procedure on the table, and the mean procedure time was about 26 minutes, and we required 1 or 2 units of blood transfusion in patients because there was a fall of hemoglobin. Now, coming on to the literature, there are various devices which can do it. The same thing without a catheter. These are aspirates. We have a post-angiojet system which works on the Venturi effect. We have a same system but with only one jet, which is a hydrolyzer. Now this device is sort of discontinued, and we have a Rotrex system. I'm not going to go to the details of post-angiojet, but what it does is it creates a negative suction, and it also lyses the clot, or sort of liquefies the clot, and it's sucked back into a bag which has a negative pressure, and that's how we remove most of the clot after liquefying it and sucking out the clot. Now, patients who are not who do not have a contraindicated for thrombolysis, in these sort of patients, we put in catheters into the pulmonary artery and lyse the clot by a direct infusion of thrombolytic agent, either mechanically, direct hand delivery or power injections, or through a injector. And here we can use a lot of catheters. We can lyse one part of pulmonary artery, one segment of pulmonary artery, main pulmonary artery, or both the pulmonary arteries. Now, this is our personal experience of 45 patients. And this slide is of a patient who was 170 kgs from Nigeria, who came for a knee replacement at our center. And after a bilateral knee replacement, has a massive PE and was totally contraindicated for surgery or for anything. And this patient was brought to the cath lab in the middle of the night. And we actually did the same procedure and put in two catheters into the main pulmonary artery after we did a thrombectomy. And the patient improved and was discharged on 7th or 8th day as usual. Now, this is our experience of pulmonary thrombectomy and thrombolysis, the combined procedures. We've done 45 patients, and in most of the patients, there was a drop in pulmonary artery pressure, and there was a significant reduction in clot burden. There was one death which was attributed to cerebral hemorrhage. So in conclusion, percutaneous catheter-directed thrombolysis and rheolytic thrombectomy are very useful and life-saving procedures for treatment of acute and massive pulmonary embolism with cardiogenic shock, and these are much better alternatives than surgery. And in patients with absolute contraindications to thrombolysis and anticoagulant therapy, percutaneous pulmonary thromboaspiration by a 10 French guiding catheter and aspirating each and every segment of possible segment of pulmonary artery actually works, and works very well. And they should be considered at large bore catheters, at least in India, are available in most of the centers. And places where we have a dedicated thrombectomy devices like angiojet or Rotrex or hydrolyzer, those devices are definitely better than these sort of devices. So with this, I conclude, and once again welcome all of you to the 5th Asia Pacific Vascular Interventional course. Thank you.
Now, since we have some time, would anybody like to ask Dr. Khanna a question, please?
It's a magnificent case, and it brings up a very important point, and that is suction aspiration was really the first means of treating clot inside blood vessels, and people have forgotten that, and it really is a readily available and cheap way of doing it. And I had somebody that I repaired a thoracic tear with a stent graft. When I did so, they embolized some of the intimal debris into one of the renal arteries and shut off the flow to the kidney. I noticed that on the way out and put a suction catheter in and was able to extract it all and save that kidney. And suction catheters work very well, just as you've shown, and they're readily available and they're cheap. It's a very good thing to do.
Thank you.
Professor Khanna, when you give thrombolysis, do you give anticoagulation as well with it? Is there any advantage of giving both, or thrombolysis alone will do initial stage?
No, normally we do a thrombolysis to take out the clot from the pulmonary artery, but it's never complete. So we put these patients actually on anticoagulation therapy unless contraindicated for long term. Initially it's low molecular weight heparin or a standard heparin followed by an oral anticoagulation. And then we look for the cause of the pulmonary embolism and DVT and other prothrombotic states. And we try to treat them as well.
Thank you.
So one question. Dr. Khan, for the time from the onset of the symptom of pulmonary embolism up to the time of duration aspiration, how many hours in your study?
Normally, it would be few hours only because acute massive pulmonary embolism presents with shock, and these patients become so sick acutely that they have to be done immediately. Otherwise, we lose the patients. All these patients which we have done are in-house patients or patients who are referred from nearby hospitals on an ambulance, and they straight away go to the cath lab and we do this.
The commonest catheter technique, thromboaspiration, most likely the export catheter commonly used.
No, the export is for
What you-
coronaries. I mean, that's too small a catheter for pulmonary
small,
arteries.
very difficult
We need real big catheters and multiple aspirations.
Okay.
So it has to be a guiding catheter or a dedicated thrombectomy device.